Good morning. My name is Lon Eisenberg from Israel, and I'm privileged to present our next speaker, Professor Michele Sterling from Australia. Musculoskeletal pain is the most prevalent type of pain that we treat on a daily basis. As physicians, we are used to give these patients medications, sometimes injections, but we see that recent guidelines on the proper management of chronic musculoskeletal pain put a lot of emphasis of physical therapy and especially on exercise. Now, there are still many open questions related to the effectiveness of this intervention or exercises for chronic pain, and questions such as, are these exercises really effective? Can we predict who is going to respond to this therapy? Are all questions, still open questions, and I think that the best person to answer at least some of these questions is Professor Sterling. Professor Michele Sterling is a world-known scientist in this area of physical therapy for musculoskeletal pain. She is a professor at Griffith University in Queensland, Australia. She has published a lot on this area. She's on the chair of the scientific committee of the Australian Pain Association, and she's going to talk about exercise for chronic musculoskeletal pain, evidence and future challenges. And please join me in giving this warm welcome to Professor Sterling, who has flown last night all the way from Australia just for being with us this morning. Thank you.
Thank you. Thank you, Elon, for that kind introduction, and thank you for the invitation to speak. As you can probably hear, I have picked up a bit of a bug on the way over, and I sound a little bit more Australian than usual today, so I apologise for that. I have no disclosures to declare. So as Elon well introduced, musculoskeletal pain is a real problem, and it's the second only to cancer as a cause of disease burden. Probably one of the reasons for this is that there is a high propensity for people to develop chronic pain regardless of the nature or the type of pain, whether it's low back pain, neck pain or whatever. The recent global burden of disease study demonstrated that the neck pain and particularly low back pain are one of the leading causes of years lived with disability. And these conditions are higher causes of disability than things such as diabetes, cardiovascular disease. So from a worldwide perspective, we really need to be able to improve disability in these sorts of conditions, of course. With regards to exercise, as to what we're talking about today, exercise-based interventions, of course, are very common. They're probably almost universally applied to patients with musculoskeletal pain. Various clinical practice guidelines for various conditions have exercise as their front line of treatment, of course, whether that be specific type of exercise or in terms of engaging in more activity and avoiding rest. There is moderate evidence of effect for exercise in probably almost all musculoskeletal conditions that we can think of. But the problem is, and probably as with other interventions also for these conditions, is that the effect sizes are generally small. So there's numerous systematic reviews out there looking at the effects of exercise and activity in various conditions. The middle one there is looking at exercise for idiopathic or non-traumatic neck pain. And I'll just show you some of the results from that trial because they undertook a meta-analysis which can be quite rare in this area. Often the authors of systematic reviews feel that there is too much heterogeneity to perform meta-analysis. So with regards to exercise for neck pain here, this is non-traumatic neck pain. We can see that on the effects on pain in the short term on the top and the intermediate term on the bottom, that we're getting this similar small effect size, I guess, from over the studies. And this is similar to this reflects what we see for all really exercise interventions for the majority of musculoskeletal conditions. Similar picture also for the effect on disability levels. Again, a small effect size and variation between what studies are finding. So of course when we're doing RCTs and particularly also systematic reviews, there's going to be some variance in how patients respond or in variances in what different studies show. And just an example of that different conditions may respond differently to exercise, I've got one example to show you here. This is a study conducted a little while ago now on cervicogenic headache, which is a non-traumatic neck pain condition. So headache coming from the upper segments of the cervical spine. It was actually a factorial design study, and you can see the intervention groups there were exercise, a combination of manual therapy and exercise and manual therapy alone. But if we just focus on the exercise group, the outcomes were similar between the intervention groups, but they were superior to control, which was act as usual and consultation with a GP. There is a variety of outcomes there, and you can see a similar picture across them. And we would say, therefore, that the exercise intervention in this study was effective, was clinically effective, clinically relevant changes, and those changes were maintained post the treatment period. This was a good result. The exercise intervention mainly involved specific neck type exercises with the aim of trying to retrain muscle control around the neck and shoulder girdles. So that was good. We then later on, or more recently, tried to replicate the trial, or the exercise intervention in a group with chronic whiplash. The exercise approach was slightly different, but fairly similar in that it started off with a motor relearning program or improving muscle control, and then transitioning towards graded activity with a component of aerobic exercise throughout. It was a bit longer, this intervention. It was about 12 weeks, and it was compared to a single physiotherapy session. And I think I said these were people with chronic whiplash. So there were differences between the interventions, but on the whole, we would probably expect a similar effect. Unfortunately, this wasn't the case, and you can see on the top graph there for pain and for disability that whilst both intervention groups, there was a downward trend in pain and disability, you could see clearly that there's no difference between the groups. So we're getting quite a different picture of response to a similar exercise intervention, in this case depending on whether the condition was idiopathic neck pain or more traumatic whiplash injury. And this is probably reflected across other musculoskeletal conditions as well, such as low back pain, arthritis and so forth. So it's not going to be a matter of that there's one form of exercise or one intervention that's going to be effective. It's going to probably depend upon the nature of the pain, and we'll talk a little bit more about that shortly. The other thing that is quite clear is despite fairly numerous randomised controlled trials, it's not yet demonstrated that one form of exercise is more effective than another. So the current evidence at the minute is that you could probably do anything: yoga, weight training, aerobic exercise, qigong, tai chi, motor control exercises, Pilates. I could go on. But probably one of the reasons is that there hasn't been a lot of comparison between exercise, between different forms of exercise, but that in overall terms there's no clear difference. The other thing that's really unknown is what dose should be prescribed, what intensity, what endurance, what duration of exercise should be given. All these are unknowns, and I think it's a bit like, you imagine if we had this situation for medication for conditions where, there's a variety of medications we can pick, we don't know which one to do, we don't know how much to give you, we don't know how long to give it for. And this is really the situation we're in for exercise at the moment. So there's an awful lot of work to be done at the moment with, I think that the evidence has been translated into practice in that people are keeping patients active, they're not resting as much, they're not going to bed in regards of low back pain, etc. And that's terrific. and the guidelines incorporate all these factors into them. However, there's still a lot of unknowns, as you can see, and a lot of work to be done there to be able to really give firm recommendations with regards to all these factors that I've mentioned. One of the reasons perhaps for the different response to exercise between various conditions could be that different musculoskeletal conditions in fact do have different underlying mechanisms. And this is just one example of some work we did comparing idiopathic neck pain to whiplash and looking at this issue of widespread sensitivity or spreading sensitization, whatever you like to call it. We can see that if we looked at pressure pain thresholds, that both neck pain groups were hyperalgesic over the neck areas, but that the whiplash group really only showed this widespread hypersensitivity into the upper limbs and lower limbs, and a similar picture for cold pain thresholds. So what we would take from this is that perhaps in the case of whiplash, it has more of a tendency to this spreading sensitization or augmentated central processes as opposed to idiopathic neck pain. The reasons for this are unclear. Other conditions show different responses as well, and there's been a lot of work, of course, in various musculoskeletal conditions, low back pain, tennis elbow, showing perhaps some widespread hyperalgesia. But if we look closely at the data, they often don't seem to be as severe as a particular whiplash subgroup. So perhaps there may be a continuum of these processes that we're really, of course, yet to fully understand. One of the other things that's started to be looked at, and there'll be more of this in the workshop after morning tea, so I won't dwell on this too much, is to show that often people with chronic pain have a different response to exercise than do healthy controls. So when a healthy control, in this case, performs aerobic exercise or stationary cycling, then there's this increase in pain thresholds. So this exercise-induced analgesia, of course. In this study, with regards to whiplash people, they get the opposite effect. So they become more sensitive following the same aerobic exercise. And this could be, of course, one reason why they don't respond so well to exercise interventions, if they're making them more sensitive, and potentially their pain may even be becoming worse. So we have to think about that. Not all conditions, though, respond in this way. And a study looking at people with knee osteoarthritis and performing upper limb strength training, not aerobic exercise this time, we can see the young healthy, the old healthy have a raise in their pain thresholds or exercise-induced analgesia, but so do the people with osteoarthritis. So again, a differential responses depending on conditions, but also possibly depending on the nature of the exercise. The first study was aerobic exercise, this one is weight training, and it could also involve where the exercise takes place. So these people with arthritis were doing upper limb weight training and they've got a lower limb condition. And as I mentioned, Kelly Ickmans will be talking a little bit more about this after morning tea. It's quite an interesting area and something that we could perhaps harness in trying to understand response to exercise or lack thereof. In recent times, there's been a push, of course, for this mantra or that exercise is medicine. And this has often been in relation to conditions such as diabetes, cardiovascular disease, and the prevention of those sorts of systemic conditions. I wondered in response to this that now people are looking at exercise in a different way, that when I was at the IAS conference in Buenos Aires last year, that there seemed to be a lot more studies around looking at basic science studies and the effect of exercise in animals. Seem to be a lot more people interested in exercise, where in the past, we'd go to an exercise session and there might be sort of the odd sprinkling of physios there. And just a couple of studies that have provided some interesting results from the basic science perspective. With this study, these authors induced hyperalgesia with the mobilisation of the limb, and then they trained the rats after removing the cast either on the treadmill for 30 minutes for 3 days a week or via static stretching of the limb. And what happened was that you can see there that the hyperalgesic responses decreased. So both exercises, wasn't really much difference between, again, the aerobic type treadmill exercise or the static stretching in this regard. This is quite interesting. And then another study I found, there's a lot more of these out there now. This is just a couple of examples, where following a peripheral nerve injury of the sciatic nerve, that the rats were then given exercise of 1 hour of running at 10 centimetres per second, which I looked up is 0.5 of a kilometre an hour, which is probably fairly fast for a rat, I'm not quite sure. And Group 1 undertook this regime for 5 days and Group 2 for a bit longer. There was no difference between the two lengths of duration, but both exercise interventions decreased hyperalgesia or withdrawal in the case of the rats. This is again, I think, interesting, and the rats were put on an hour of running. That's quite intensive. I doubt that if we had a patient in with radiculopathy, lumbar radiculopathy, that we would get them to run on a treadmill for an hour. But maybe it does have some indication that perhaps some of the exercise trials that have been undertaken, we may be being not intense enough. I don't know, it's just a thought to put out there. A lot of the interventions so far have been more on motor control retraining, lower load exercises, not really pushing the patients too much. And this could be an area that we need to look at a little bit more. The other interesting thing with this study was that they did find physiological changes in preventing nociceptor sprouting and changing transporters and things and the like. So again, quite interesting changes, physiological changes in response to exercise very soon after, a quite significant injury that would be significant in humans. So when we look at the question as to who responds to exercise, we can't really tell you that much either. So in low back pain, a couple of studies that have looked at this. One study reported that self-reported clinical instability, so if the person felt like their back was unstable, that predicted response to motor control exercises. But another study there looked at various measures, as you can see, and couldn't find any that predicted a response to McKenzie-type exercises. We really don't know. We would think intuitively and clinically that some people respond and others don't, but at the moment there doesn't seem to be any real clear-cut indicators as to who those people are. In an early trial we did in whiplash injury, with chronic whiplash, with a mainly exercise, it was a multimodal physiotherapy approach that was mainly comprised of exercise. We got a clinically relevant effect, even though it's fairly modest again, compared to self-management. But those people with both mechanical and cold hyperalgesia here didn't respond as well. So we wondered whether these features of central augmentation, if you like, may influence the effect of an exercise intervention. Unfortunately, though, when we tested, this was a post hoc analysis, and when we tested these hypotheses a priori in that larger trial that I've already talked to you about, we couldn't find anything that predicted responsiveness, okay? And this was doing quite a robust analysis of using these baseline predictors in a interaction term, as you can see, which is the correct way to do these things. So neuropathic pain scores, post-traumatic stress symptoms, hyperalgesic pressure pain thresholds, cold pain thresholds, catastrophizing, nothing came out as a significant effect modifier. However, as a hypothesis-generating exercise, I've gone back, and this is a little bit naughty statistically, but classified the two groups as responders and non-responders. So this is really just a hypothesis-generating exercise. And what we found was that those who didn't respond at baseline had significantly higher levels of post-traumatic stress symptoms in the three subcomponents. So that might be something that we need to think of as well, not just pain processing mechanisms or nociceptive processing mechanisms, but also the psychological presentation of the condition could be preventing in some way the effectiveness of the exercise intervention, and that's something we're looking at as well. If we just pop back quickly to this trial, the PROMISE trial, this was quite disappointing for us, as you can imagine. So after 12 weeks of intensive rehabilitation with a state-of-the-art exercise approach, the general effect and group effect was no different than a single session of physiotherapy and advice. So we hypothesised about this. We couldn't find any effect modifiers particularly. we're at a bit of a loss. What's going on here? So what we've decided to do, and this is in its early stages, is why don't we ask the patients what they thought of the intervention? Why don't we ask them what they felt about it, what they thought of some other things they needed? And so to date, we've managed to track down some of these patients and ask them in a semi-structured interview various questions about the trial. We're still going through this, so this is quite preliminary data, but there's some interesting findings, I think. So what some of the patients said about the exercise intervention. So remember, there was no effect between this and a single session of physiotherapy. So some of the things, it taught me a lot of stuff which I use to keep myself good now. It was a valuable program. Maybe this person responded, I'm not quite sure. If I hadn't done the program, I'd be in a wheelchair. I found it absolutely wonderful, and everyone was delightful, and just getting ideas and knowing that people were seriously looking what was going on and taking the stress out of the situation for me and just giving me other options of how I move and how I sit and that sort of thing. No one, until I went to Conrod, that's the research centre, was even a slightly bit interested in whether I had range of movement in my neck, whether I had range of movement to lift my arms up without hurting. No one was really interested in the pain I had at the base of my skull. So the things that they seem to be telling us seem to be factors, to me, unrelated to the exercise program itself. And if we highlight some of them, the second statement there, that person may have some catastrophic thoughts about being in a wheelchair. We have the second person talking about the stress of the whole situation to them, and the last person perhaps feelings of injustice and not being validated in terms of their condition. Interestingly, also the last person also did want information about physical things, about how to move their neck, about how to move their arms. They all seem to like the program. They all seem to like the physiotherapist that delivered the program. But there's some things here that we can work on in terms of perhaps adding to an exercise program or pre-treating people in the beginning before we institute the exercise program that may help, as you can see. When we also asked the patients what other things would they thought should be added to the treatment that would have helped, and some said they would have liked another follow-up so that the physiotherapist could check what they were doing. And a lot of them reported problems prior to coming into the problem. These were chronic whiplash people of at least 3 months duration, and most of them were longer than that. About that the people they'd been to before couldn't provide them much information about their condition and about what to do about it, which I think is quite sad in terms of the clinical guidelines now available for this injury, that people are still getting to the chronic stage and feel like they don't have useful information about their condition and what they can do for it. So the last thing I just wanted to talk briefly about is looking at more targeting interventions. And one of the moves afoot is this idea of subgrouping or stratifying people and trying to match interventions to them. This is in the physiotherapy exercise world, or adding additional interventions to exercise-based ones. And probably the most well-known, of course, approach for targeting interventions is the start back tool that I'm sure most of you are aware of. So this is for low back pain. So in the acute stage, they undertake a questionnaire and the patients are stratified based on their risk. And then treatment is targeted towards that stratification level. So the low-risk patients receive exercise, activity-based physiotherapy, whereas the high-risk patients receive what they call psychologically informed physiotherapy or exercise, where the physios undergo some training in psychological interventions to add to the already active exercise approach. And these results of this study show quite a good promise, I think. So the far graph, number A, there is the overall effect between act as usual. And then we have the 3 subgroups. The low-risk group, of course, haven't really got that far to move, but we're getting much better effects and clinically relevant differences in both the medium and high-risk group. So again, adding something to an exercise intervention for those people that need it may be one way that will help improve outcomes for these conditions. We've tried to do a similar thing in whiplash injury, and we've developed a clinical prediction rule. We've used the measures you can see there included variables. We had a whole lot of cohort data. We didn't have some measures that we hadn't taken, things such as expectations of recovery, perceived injustice, those other factors that have come out more recently as perhaps being predictive. So we couldn't include them in our model. And we wanted this to be useful, particularly for GPs. So we wanted it to be quick and easy, and so that they may in fact use it. So on the post-traumatic stress diagnostic scale, we found that the symptoms of hyperarousal were more predictive. So we used this scale, as you can see the items there, in the final clinical prediction rule. So what came out was their levels of disability, first of all, on the Neck Disability Index. And if people were fairly high on that questionnaire, moderate to high, they had greater levels of hyperarousal symptoms and they're aged over 35. They were predicted at high risk. And the other arm, lower levels of pain-related disability, lower age, and predicted to be at low risk. And the middle group, of course, that was never going to be black and white, that could have gone either way, and we would also call medium risk. The specificity of the tool of each arm, the high risk and the low risk arm, is very good, about 90%, and the sensitivity is a bit less. I haven't put the data up to save time. But what we're looking at now with this again is this sort of a different approach to management, targeted approach depending on the risk of the patient. And this is underway, this pathways study. So we would think that those at low risk again would benefit well from an exercise active intervention, but those at the other end, the high risk, are going to need further assessment in addition to their exercise intervention. So just to sum up and to look at where do we go from here, and I've outlined some of the future challenges for investigating exercise interventions, and as I said, a fair bit of this has been translated into research, but it's more than the simple dogma of keeping active, don't rest, do some exercise, doesn't really matter what. We need to know a little bit more. So just summing up, predominantly exercise and activity approaches have only modest effects, and perhaps this isn't so unexpected in those people, particularly at medium or high risk, or those with a more complex presentation in the chronic stage. The optimal type, frequency, intensity, duration is unknown, and we probably need a better understanding of condition-specific mechanisms to be able to outline these factors with a little bit more definite about them. The exercise it may be more effective, this is people with musculoskeletal pain, more effective in some, but we still can't clearly tell you who they are. So at the time being, we don't have any concrete evidence of responders and non-responders. But people need activity and exercise. It's very important. If we're going to prevent these more chronic diseases, diabetes, cardiovascular disease, which are going to really be problems for the world in the future, then we need to be able to find a way to get these people back to exercising in a meaningful way and that they can do. And one of the things that we're looking at, and I think another option that might be looked at is, in addition to subgrouping people, is then to add additional interventions that target risk factors. And these may be psychological factors that we've outlined, but also pain modulation processes and combining exercise some way, perhaps with medication or other interventions that may assist in this regard. So finally, I would just like to thank the rest of the team, especially Dr. Carrie Ritchie, who's done a lot of work on the clinical prediction rule in our group. And lastly, of course, funders of the research who, without them, of course, it wouldn't be possible, particularly to do the large trials that we have been fortunate to be able to undertake. Thank you.